I thank you for being here, for giving me the opportunity to talk with you. I thank the foundation for inviting me. I want to have a sort of a different conversation with you than the conversation that David had. David talked about your reactions to the everyday life things, the things we interact with, and what makes us afraid, and how we react to them. I want to sort of move beyond that to the situation that I face as someone who works with clinicians, works with public health officials about managing, fundamentally, risk data. Because we live in a world right now in which there is a lot of risk data. But I think it won't be surprising to you after you've listened to David to hear the fact that risk data does not always translate into the thing that really matters, which is risk understanding. So how do we translate all of the facts and figures and statistics and epidemiological studies and clinical trial data into understanding that guides our health policy, that guides an individual who must face a difficult health decision? So let me start by telling you a story. This is a story I ran across about 5 or 6 years ago. A guy by the name of Nick Curzon wrote a nice little article in Newsweek. And he's a filmmaker. He lives in New York City, or at least he did at the time. And he gets diagnosed at, I think, age 28 or 29 with lymphoma. He talks with his doctor, and his doctor says, actually, we've caught this pretty early. The treatments are quite good. You've got a 90% chance of surviving 5 years given treatment. And he doesn't quite know what to do with that. He doesn't quite know whether to think, to feel good, or feel bad. And so he wrestles with, well, what do I make with this 90%? How do I think about it? Now, people say, you get diagnosed with cancer, you find God, you find your future. No, he didn't find God. He found poker. And he tells this lovely story about playing a poker game with, he describes this Wall Street cowboy. And he's got a full house, but not a great full house. And there's one more card left to turn over. And he knows, based upon the cards that are out on the table, that there's probably 4 cards left that he hasn't seen that would give his opponent a better full house and he'd lose the hand. And there's maybe 40 cards left that he hasn't seen between his own hands and what's out on the table. So he's got 9-to-1 odds or so of winning the hand. So what do? You're a poker player, you got 9-to-1 odds of winning the hand, you bet big. And he does. And he loses. He says, you know what? When you're a poker player, you know this is going to happen. And poker players train themselves to get up from the table because of the fear that they feel, that bad beat. They knew they were going to win, and then they lost. But poker is played by the year, not by the hand. Poker players train themselves to make the same call every single time. And if they can't make it, they shouldn't be at the table. Because they know that if they've got a 9-to-1 odds, they need to be betting big, because that's how you win money at poker. And I think his story is interesting because it highlights one of the most fundamental points about managing risk when you think about making decisions, which is this. Patients and clinicians are fundamentally operating at different levels. Patients experience outcomes. You live, you die. You are never 90% pregnant, right? You're never 90% alive. Physicians see populations, right? And Curzon talks about he wants his clinician to make the same bet on his treatment regardless of whether the last patient he treated for lymphoma lived or died. He doesn't want the clinician's judgment to be influenced by that emotional reaction. He wants his clinician to play the odds, even though he's going to be afraid, even with a 90% chance of survival. So that's the problem we've got to wrestle with. How do we take risk data and make it risk understanding? And to help walk you through this, I'd like to introduce you to some patients. I want you to meet Robert, and I'll meet if you meet Sarah, and then a young couple, Paula and Joseph, and then lastly I'll have you meet BJ. These are some patients who will illustrate the kinds of issues that we have to face when we think about managing risk in navigating the healthcare system, in navigating our own lives and our own health. So let's start by imagining Robert. So picture your stereotypical white middle-class guy who's probably got a few extra pounds. And he knows he might actually be at risk for having a heart attack. And so he does what many of us do these days. You go online. And what does he find? He finds one of these online risk calculators. He's like, cool, I can learn what my risk is. Calculate your heart disease risk score. Okay, what do you have to do? Well, you have to enter your risk factor info. So he sits down and says, okay, how much do I weigh? Okay, how much do I really weigh? Then he tries to remember what his blood pressure was. Whether he gets that one right is a whole other question. And cholesterol, weight, other risk factors. And at the end, he gets his result. And the calculator tells him, your 10-year risk of cardiovascular disease is 14.52%. Okay. So he goes out and he talks to his friends, let's say over a barbecue. He says, what'd you do today? Well, I went online and we used this calculator. It told me what my risk is. But I'm still confused. Am I at high risk or not? Right, Robert just got a precise risk estimate. And in fact, if that calculator is good, that may be the best risk estimate modern medicine could give him about what his risk is of developing cardiovascular disease. But is he informed? Can he use that information to help guide what he's going to do? Doesn't sound like it to me. See, that's the problem. There's a couple problems here. One of them is numeracy. Numeracy. What is numeracy? Well, if we talk about literacy, the ability to read, understand information, make sense of it, numeracy is the ability to look at numbers and make sense of them, to derive meaning from them. And when you're talking about risk statistics, that's a big issue. Now, many of you took the survey that was distributed as part of the registration process. Rolled into those were some questions related to numeracy. But before I get to those, I want to ask you a question, and I'm sorry, if you talk about numeracy, you have to talk about math tests. So I'm going to give you a math test. Which of the following numbers represents the biggest risk of disease? 1 in 100, 1 in 1,000, or 1 in 10? Everybody? 1 in 10. Very good. 1 in 10. Now, here's the statistic that will make you more nervous. When this question was included in a test of college-educated American adults, 20% of them get it wrong. Now, notice, however, that part of the problem here is the way in which the information is being presented. Right? If I had reframed this question this way, I bet you'd have gotten it right. I bet everybody would get it right. Which of the following numbers represents the biggest risk of getting a disease? 10 in 1,000, 1 in 1,000, or 100 in 1,000? Same risks, right? A whole lot more transparent. Now, if you want to talk about measuring numeracy, you're not going to give a patient a math test when they walk into the clinic, right? You can imagine that, sit down, put on the gown, now here's your clipboard, fill out the math test, right? That ain't going to happen. But what we can do is use things like subjective measures. And I, along with some colleagues in Michigan, developed a few years ago a subjective numeracy scale. And these are the questions you guys saw if you filled out the survey. How good are you at working with fractions? How good are you at telling how much a shirt is going to cost if it's 25% off and no cheating with your iPhone? How often do you find numerical information useful in your day-to-day life? We know this. Right? I am a numbers guy, okay? Look, I'm an academic. I do risk for a living. I'm a numbers guy. And frankly, so are most of you. Right? When you answered those questions, I tabulated the results. On a 1 to 6 scale, when you add up those 3 questions, the average numeracy in this room is about 4.9. That's not particularly surprising. But if you go into a different population, you get a different answer. People know if they're uncomfortable with numbers. And this isn't just about ability, by the way. You notice that last question, how often do you find information to be useful? That's a preference thing. That's a question that measures, do you go out of your way to look for numbers? Or are you somebody who says, yeah, don't tell me the numbers, just tell me what, give me the gist. Give me the emotional response that I should be having to that number. Here's the problem. Low numeracy skills do a whole heck of a lot of things, and I probably won't cover even a small fraction of them, but a couple I will talk about. People with lower numeracy skills are more confused by extraneous information. You give somebody a big table of risks, a highly numerate person will say, okay, here's my age, here's my weight, this is my risk. They get it. A less numerate person is like, I have no idea what this is. Put it aside. And less numerate people are more influenced by the way in which present information, right? The highly numerate person, it doesn't matter whether you say 1 in 10 or you say 100 out of 1,000. It's the same thing, because what a highly numerate person has in their mind is that innate representation of the proportion. A less numerate person just remembers the surface representation. So they only remember 1 in 10, or they remember 100 out of 1,000. And you know what? 100 out of 1,000 seems a lot bigger than 1 in 10. But there's another problem with what Robert got. Robert got his chance of developing disease, right? He got 14.5 men out of 100 will develop cardiovascular disease. What he did not get was the flip of that. What he did not get was a reminder that 84.5 men out of 100 will not get cardiovascular disease. Because a risk is a proportion, it's a ratio, if you want to talk about a statistic. And I recognize I'm working the probability side here and not the outcome side. I'll get to the outcome side, don't worry. But you need that balance. So how do you do that? There's lots of things. One, you can just tell this kind of information, but I'm a big proponent of visual displays. Because rather than just require somebody to think in numbers, maybe we can help them look visually and understand risk. And so I advocate for what we call icon arrays, or sometimes we call them pictographs. This is an icon array used to represent a woman's risk of developing breast cancer. What you see here is the whole population, 100 rectangles in a matrix. The colored ones are the events, but the gray ones are the non-events, and you have this innate representation that helps you see how much risk do I face and how much is the chance that nothing will happen. Right? These types of arrays, there's a whole slew of studies, and I'll show you some of the references just because you'll nod your head and say, yes, there are references, not because I think you'll actually look them up. But icon arrays are simply better graphics for talking about risk. Don't try and do a pie chart, please. Please don't do a pie chart. Pie charts are great for showing part-whole relationships, but have you ever tried to figure out whether it's a 12 or a 10 in terms of how far that little radius goes on a pie chart? No. Icon arrays work better because you can count them, and you can see the relative height, and you can see the relative area, and those non-events are just as salient as the events. And when you use icon arrays, the research evidence over the last 10 years has shown it helps the less numerate make sense of numbers. It reduces that denominator effect that I was talking about, that 1 in 10 versus 100 out of 1,000. You give them an icon array, they figure that out. It makes people less afraid of side effects because they recognize how often they don't occur, not just how often they do occur. And it clarifies that what difference it makes to your risk. Not just are you at risk, but what difference does it make if you have a treatment or if you quit smoking? And right now you're all saying, yeah, thanks. How in the world am I supposed to make one of these things? Good question. Because unfortunately, I have not yet convinced Microsoft to put this kind of a thing into Excel so that you'd all already have this. But in the meantime, I am pleased to announce today the alpha release of iconarray.com, a website that you can go to create your own icon arrays. Tailor them to whatever risk you want. Tailor them to the shape that you want. Download embeddable code to use in web-based applications. Just like you'd embed a YouTube video, you can embed an icon array. There's a picture of this screenshot in your packet today. Feel free to use it. Because my goal as a communicator is to get better evidence-based risk graphics in practical use. But let's go back to Robert for a second. What did Robert want? Right? Why do you go to a risk calculator in the first place? You go there because you want to know whether you're supposed to do something. Right? He didn't want a number. He wanted to know, am I a person who's at high risk? Do I need to be going to talk to my doctor? Or am I okay? He didn't get that. What he got was a number. So he's not happy. He didn't get what he needed. And so now I'd like to talk about information evaluability. And the information evaluability is quite simply the difference between a number, what a number is and what a number means. So here's some other questions that were in your survey. Is this a little risk, a lot risk, or do you have any clue for a woman to have a 2.1%, 5% 5-year breast cancer risk? How many people think, show of hands, how many people think this is a lot of risk? How many people think it's a little risk? How many people think no clue? So let me calibrate you. If you're, say, a 65-year-old woman, that might well, based upon a variety of other risk factors, that might well be a fairly average number. It is, however, above the threshold that the clinical trials for tamoxifen and raloxifene that used to classify women as high risk and hence eligible to take medications to reduce that risk. So this number would classify you as high risk because you are, and make you eligible for prophylactic intervention, even though, as a 65 or 70-year-old woman, that might well be average risk. Now what do you feel about it? A little complicated, right? Blood pressure, 88 over 58. Little risk? Lot of risk? No clue? Well, and that's the point. And that's part of the point, right? You can't separate the probability from the outcomes, right? You've got outcomes that might be transient, and you've got outcomes that might be long-term and catastrophic. And your feeling about this number has to somehow incorporate both of those potential types of outcomes. Dave was talking about radon. Here's a number. 8.5 picocuries per liter. Okay, raise hands if you have any clue what a picocurie is. Ooh, I'm impressed. Any clue? Now, when we asked this in the survey, 70% of people who responded said no clue. And I can appreciate that. Now, if you I live in Michigan. Michigan has a lot of radon problems. You can't sell your house really until you do a radon test. And you kind of want to know what that number means. Now let me give you some calibration here. EPA threshold for what they call an action threshold for asking you to say you should do something. You should put in equipment to shunt the air out of your basement to try and lower your risk is 4. 8.5 is somewhere equivalent in terms of lung cancer risk to smoking a pack of cigarettes a day. You didn't know that? Come on, we gave you the number. We told you the number. Platelets. Okay, I know the doctors and nurses in the room will probably pick up this one, but I've given you the number here. I've given you the normal range. And this is clearly out of range. But is it way out of range or a little out of range? Is this are you going to start bleeding immediately with this, or is this just a low result? Do you know? If you're a cancer patient, you really ought to. Because you ought to know whether or not, when you get your test results back, whether you need to be walking back into the emergency room to get a transfusion, And these days, as we're talking about electronic medical records and direct patient access through patient portals, we're going to have patients who get this number by themselves, not necessarily with the clinician there to interpret it for them. So how do we make this number meaningful in a way that will help them guide their own behavior in that moment? Right? Robert wants to know if he's high or low risk, but he gets a number. So what do? How do we help him? Well, we can give him comparison standards. My risk number is this, but how does it compare? It's higher or lower than other people's risk, or it's higher or lower than some other standard. That helps to make information more evaluable, more meaningful, because frankly, context is critical. The meaning of a number depends far more on what you give in addition to that number, what the standards of comparisons are, than what the first number was. And we evaluate numbers in comparison. I'll give you an example from one of the first papers I ever published. Imagine you're a couple, you're trying to decide where you want to go for fertility treatment. And you look, and here's a clinic, Fertility Partners. It's all pretty close by, it's about 15 minutes away. And they've got a 33% success rate in their trials of in vitro fertilization. And they do 200 of these procedures a year. How good of a clinic does this seem like? Not bad, right? You'd think this would be pretty reasonable. Well, whatever you might think about this, now look at Reproductive Associates. It's a farther away clinic. You know that's going to be a pain because you got to go there day after day after day. They got a 40% success rate. How are you going to interpret that clinic? And more importantly, how are you going to interpret it if you look at it by itself versus if you look at it side by side? And here's the data. If you look at these by themselves, people pick the close-by clinic. They think it's better, right? You know it's convenient. You just don't know what to do with that success rate. But when you put them side by side, of course you're going to pick the one with the higher success rate. That's what really matters here. We didn't change the numbers. All we did was make you look at them one at a time versus side by side. And now all of a sudden, that weight that you put on the success rate, the most important statistics we've given you, changed. So let's imagine now you're trying to decide about your own breast cancer risk. And a risk calculator spits out that you've got a 6% risk. What do you think about that? Are you going to be afraid of it? Are you going to be relieved by it? Well, if I tell you that the average woman's risk is 3%, you're probably going to be really worried. If I tell you that the average woman's risk is 12%, you're going to be really relieved. I haven't changed your number at all. All I've done is put it into a different context. Easy to evaluate data have intrinsic meanings. We always use them when we do decisions. I will always know that the clinic that's only 15 minutes away is going to be just better for me. But that doesn't mean that that's the only thing I'm going to pay attention to. If I have the opportunity to think about the risk statistics in a way that's meaningful, then I can put it in context. But hard to evaluate data require reference standards to be meaningful. And we will ignore those data unless we have such standards. Now, what does this mean for helping Robert? It means that we could have helped Robert by giving him some other reference standards when he got his risk calculator result. But notice the main message here. The meaning he would take away from it is going to depend primarily on which reference standards we give him, more than what his number was in the first place. So enough about Robert. Let's talk about Sarah. Sarah is a middle-aged woman who has the unfortunate circumstance of being diagnosed with early-stage breast cancer. An unfortunately common occurrence. And she wrestles with the choices of surgery and decides that she's going to have a lumpectomy, to have her relatively small tumor cut out, and not to have a full mastectomy and cut off her breast. But then she faces one of the actually more difficult decisions that cancer patients can sometimes face. She has to think about adjuvant therapies. These are the therapies that you might take after your surgery to try and reduce the risk of cancer recurrence, to keep that cancer from coming back. And I'll simplify this, but you can basically boil this down to there's a couple choices. There's chemotherapy agents that will attack the cancerous cells. There's hormonal therapy agents that will suppress estrogen, which often fuels certain types of cancers. And her clinician says, well, I can help you. Let me tell you whether or not what your risk is. Are you somebody who's going to have their cancer come back? And the clinician uses an online tool and comes back and says, good news, you have a low risk of recurrence. And so Sarah goes back to her husband and says, so they tested my tumor, looked at its characteristics, looked at its genetics to see if it would be likely to come back. And they said I have a low risk, but I'm still confused. How low is low? Won't chemotherapy help some? Probably. Do I want to try it anyway? How do you make this choice? Right, is Sarah informed about her risk? Well, she got what Robert wanted, right? Robert wanted a high or a low statement. She got that. She's not happy because that isn't enough for her decision. She needs to understand the incremental risk reduction that she would get by taking chemotherapy agents or hormonal therapy agents and decide, is that worth what she's going to have to bear to do it, right? How low is low enough for chemotherapy to be worth it is a risk to values question. She doesn't just need risk information. She needs somehow to take a very complex set of statistics and have it presented to her simply enough that she can make sense of it. Now, this is a screenshot from Adjuvant Online, one of those online tools that I mentioned that clinicians can use. What you can do here, and this is designed for clinicians, not to be seen directly by patients, what you can do here is put in the patient's age, their tumor characteristics, whether it's sensitive to estrogen or not, whether the cancer has been found to spread into the woman's lymph nodes or not, and get tailored prognostic estimates of that woman's chances of survival with different therapy options. Now, what's good here? There are, in fact, a number of good things here. One, we're talking about personalized risk estimates. I'm not saying, well, the average woman gets some benefit from taking chemotherapy. No, I'm not the average guy. You're not the average woman. I don't want average statistics. I want personalized statistics. And these kinds of tools enable us to have conversations about individual patient circumstances. And that's great. I have great admiration for the clinicians that develop these types of algorithms. And I give them credit for using visual displays. Not the ones that I would have used, but at least they're using visual displays. And in fact, they do another important thing, which is they talk about the incremental effective treatment, specifically. But there's a problem here. And let me go back for a second. There's a lot going on this page, right? You've got 4 different therapy options. You've got a whole bunch of things you can change around to change your personal characteristics. You've got 4 different colors in those bars that you have to figure out what they mean. How are you going to process all that? And more importantly, is a less numerate person going to be able to process all that? As it turns out, there's good work that's coming out now that really makes the argument the answer is no. And that in fact, in our drive to follow in the American system, the legal responsibilities for full information, we bombard people with so much that they don't take away anything. And that many times, less is more. That by simply focusing our presentations on the decision-critical information, we can not only help highly numerate people use information, but we can actually help the less numerate people figure out what the heck is going on. So, would you want, if you were a breast cancer patient, would you want to see this? And this, by the way, is the patient handout from Adjuvant Online. Would you want to see this if you were trying to decide, do you want to add, let's say you decided you were going to do hormonal therapy, which if you had a patient with a tumor that was sensitive to estrogen is probably going to be pretty close to a given. Would you want to see this if you were trying to figure out the incremental benefit of chemotherapy? Would you want this? 2 graphs, simple colors, and a statement that says very simply, 1 more woman out of 100 is alive due to additional therapy. Now, I can't make the choice. You could say chemotherapy is worth that 1% risk reduction. You could say no. But I don't know about you, I'd rather see this if I had to make that kind of a choice. So now let's talk about Paula. Paula and Joseph. Paula's pregnant with her first child, but because she's 37 years old, she gets that label. My wife hated this label. That advanced maternal age label. And so her doctor says, hey, you know what? You actually are at, we need to talk about the risk that your fetus might have Down syndrome or some other kind of chromosomal problem. So she's offered a screening test, blood test, to help refine her understanding of what her risk is of having a fetus with a problem. And she gets the test. She says, okay, I should probably get the test. And she gets the results. And the results say, your test was positive. Your risk of having a fetus with a chromosomal problem is 5 in 1,000. And so Paula and Joseph go back and they're talking with themselves and they're talking with other people. And they say, you know, we got the screening test done and it said we're positive. So I guess we have to get amniocentesis, even though it might cause a miscarriage. Wait a second. Are they informed about the risk? Yeah, they are. They've got a number that assesses, as best we know from the science, what the likelihood of their fetus having a problem is. Are they using that number? No. They feel like they have no choice. They must act. Why is that? We gave them a number. And in fact, if we'd done our jobs, then we would have also given the number that lets them know that that means that 995 out of 1,000 times there is no problem. And yet they still feel like they must act. So I did an experiment a few years ago to explore this type of decision. It was it was a survey experiment, hypothetical, but you'll see where I'm going in a moment. Divided people into two groups and asked them to imagine that they were, they or their partner were pregnant. And one group was told that based on age and family history, the risk of fetal problems was 2 in 1,000. The other group was told it was 12.5 out of 1,000. And I'll be clear here, they were not told the high risk and low risk labels that you see on the slide. They were just told the numbers. Not surprisingly, the people who got the higher number were a little bit more worried going into the process than the people who got the lower number. Then we asked them, do you want to take a screening test, just like in real life? And most people said, yeah, I do. I want to learn more. And then we gave everybody the same answer, the 5 in 1,000 number you've just seen. But we didn't do it quite the same way. What we did was we randomized people into 3 groups. One group got the number only. They got a result back and it said, your risk is 5 in 1,000. Second group got the same number, but before they did, they got a 1-sentence additional introduction that said, your test was positive if it showed a higher risk, or your test was negative if it showed a lower risk. And just because those positive and negative labels are kind of backwards, right? A positive test is a bad thing and a negative test is a good thing. We also included a third group that got that got normal and abnormal labels. Now, I'll be honest, I swore up and down when we designed this study that we'd get different results for the 2 different kinds of labels. We didn't. So what I'll show you in terms of the results is it collapsed across the 2 labels groups. But then we asked them after to do this, okay, how interested are you in amniocentesis? Knowing that amniocentesis, and we told them this, knowing that amniocentesis includes a potential risk to the fetus, risk of causing a miscarriage. Well, the no-label group here didn't matter which group they'd been in before. They pretty much had made the same decisions either way. It didn't matter if they'd had a lower number that then went up to 5 or a higher number that went down to 5. Pretty much even. But that labels group, boy, not the same. 20 percentage point difference in that what they're expressed was their interest in amniocentesis. And let me say this again. All we did was change one single sentence to add that label. And all of a sudden, people are making very different choices. That's the power of labels. Labels change the way we think about risk. And in fact, labels are so powerful that if you give somebody a number and label it as high risk, as low risk, as normal, a week later, they don't remember the number. They remember the high. They remember the low, but they don't remember the number. Now, whether that's a good thing or a bad thing depends upon your situation, right? If we're talking about Robert, maybe that's a good thing, right? Robert wants to know if he's high risk. He doesn't need the number. If we're talking about Paul and Joseph, I'm not so happy anymore. I think they have to face a decision in which knowing that number really is critical. And so giving them that label, maybe you thought you were being helpful. Maybe they even asked their doctor, is this a high risk? Did the test come back positive? But that helpfulness undermined their ability to process the numerical information that we gave them. And if they're not going to process that information, why are we doing the test in the first place? So now let me introduce you to my fourth patient, BJ. BJ is 28 years old. He exercises, he's married, he's expecting his first child. He gets a huge bruise from a racket. He's diagnosed, he's got an extremely low platelet count. So what are BJ's choices? Well, one is management. He can just keep going, give him a 100% chance of surviving a number of years, but not a long-term time. Because you can't keep getting platelet transfusions over and over and over again. Eventually, they stopped working. Or you can take one of the biggest risks medicine has ever come up with, bone marrow transplant. 70% chance of a cure, long-term, with some complications risk, but he'll be alive. Or a 30% chance that the transplant itself will kill him. How do you make that choice? Right? BJ says, look, I met with the doctors. They told me all the risks if I do or do not do the transplant. The chance it'll work, the chance it won't. But I'm overwhelmed by all the numbers. How do I make this choice? Right? BJ's problem isn't so much about the numbers. It's about what do those numbers mean for him. He's informed about the chances of success. But he's not really informed about the risks. Because being informed about the risks of that transplant requires thinking about what would he lose on different pathways. Right? In the short term, he could lose some imminent events he might care about. He could miss graduations. He could miss weddings, projects. He could miss lots of things. He would also potentially have a very lower quality of life. Transplants are not easy. In the long term, if he doesn't do the transplant, he could miss some very long-term important things, like being a father to his children growing up, or his long-term career goals. Right? If we want to talk about that bad event happening, we can't just say it happens. We have to say, what does it mean to us? What does it mean to him to be alive or not alive at different points in time? David mentioned this, and I will say this as well. Risk is probabilities and outcomes. And just sort of saying, well, you could get cancer or you could be dead isn't actually the end of the conversation. We have to get past there to really imagine what might happen. And as an example, BJ might face something like graft versus host disease. Graft versus host disease is when the transplant starts to attack your own body. It can be truly horrific, leaving people with quality of life. They didn't want to be alive to live. And unless you've really thought about and imagined that, how in the world do you keep going and make sense of whether you should take the risk to go down that pathway or not? So here's some takeaways before I have a piece at the end that I want to talk about. How we present risk data often matters far more than what those numbers are. Right? Risk data can quite literally be meaningless if you lack the numeracy skills to process it, if we don't give you the comparative statistics to put it into context, if the non-events are hidden so that you only focus on the events, if the categorical labels you happen to slap onto them in the name of being helpful overwhelm our ability to process the numbers in the first place, or even if we get all the numbers, but we just can't process the outcomes, the possibilities that these chances are talking about. All of those things impede our ability to make sense of numbers. So simply giving patients the right number doesn't mean you've given them meaningful answers. And I love this cartoon because I think it captures that spirit. What matters is what happens at the end there. How do we feel about it? How do we make the decisions that we have to face? So now let me pause and try and tell a story. And I'll try and do it quickly, but I'll see what I can do. You think about how do we get from risk data to risk understanding. I had the pleasure of seeing some presentations by a wonderful speaker, a guy by the name of Sekou Andrews. He's a motivational poet is the way he calls himself. And he does a presentation that talks about, I'll start someplace, it'll take me a while to get there. He does a presentation in which he starts by talking about calculating your net worth. Right? You know what I'm talking about, the accounting term. You take your assets, your house, your car, your stocks, your bonds, you add them up. You subtract from it your liabilities. Those car loans, those student loans, that mortgage, et cetera, and that's your net worth. Well, maybe we can learn something the way we think about it. Because Sekou went beyond that to ask this question. What is your net health? Do you even know how to calculate your net health? I mean, let's ask some questions. What are your health assets? Do you have the endurance you need to get through each day? Do you have the strength to lift up your grandchildren to play with them? Do you have the mobility to get where you want to go in life? Those are our health assets. Now let's look at those health liabilities. All right, let's be honest. How many extra pounds are we each carrying around? What physical or mental pains do you have to bear the burden of each day? And I'll be honest, this is another big liability. Do you really not have the self-control to skip that second piece of pie? Right, those are the liabilities. And our net health is dependent upon thinking about those things. But if we want to talk about risk, we've got to get past just the balance sheet of our health. We've got to get to the point in which we're assessing how we want to face risky decisions. And if you want to draw analogies, what do we do when we make risky decisions about investments? Your 401k plan, for example. Okay. We've got all different kinds of investments. You've got there's the safest one. You can take your money, you can stick it in your mattress. It doesn't work so well. Then you got your T-bills, your blue chip stocks, maybe even getting into some small caps or junk bonds. Right? Because in the investment world, we're more familiar with the idea that in order to get a bigger return, you've got to get a bigger risk. You've got to be willing to acknowledge that you might have some ups and downs. You might lose something to have the higher expected return. Well, now let's look at this from the health standpoint, and let's ask some important questions. Right? What was the return on your last annual mammogram? Do you know? You, sir. Do you think your next colonoscopy will yield as good of a return as your last one? Isn't that the question we ought to be asking if we're talking about a risky decision? Because that colonoscopy is not without risk, but it has benefits. How do we ask those types of questions? Or even better, the one that comes with all the kinds of chronic health management issues. Are you willing to run a rare but known risk to your health in return for a higher expected return on your body? That's what we mean when we talk about taking a statin to lower your cholesterol, taking an antidepressant to to help you get more out of life, but there's some risks associated with it. Those are the questions we need to be asking. And if, God forbid, you get diagnosed with serious medical illnesses and you need to talk to your doctor, maybe we ought to talk to our doctors the way we talk to our investment advisors, right? Maybe we need to ask questions like, what was the past return on this procedure in the clinical trials? Or, more importantly, what was the variance on the return, right? If you want to look at mutual funds, you can figure out, it's published, what the beta was. How variable is this? Is this a stock that goes up and down a lot, or is this a very consistent? Well, when we talk about doing medical therapies, we've got the same problem. Is every patient helped, or only a few? Do you know? And shouldn't we know? Shouldn't we at least have that conversation if we're going to be informed consumers about medicine? So let me make one point, and I'm going to be very, very clear about this. When we go out and we make risky decisions in the investment world, what do? Right? Do you get stock tips from your uncle? Do you just buy a car, which admittedly is one of the bigger risky decisions we make? Is this going to be a reliable car or not? Based upon whether the salesman says, hey, yeah, it's reliable? No. Right? You do the research. You go out, you get your Morningstar reports. You see, is this a 5-star mutual fund? Is it a 1-star mutual fund? And you can have a 5-star fund that's highly variable, but it's got big return, or it's very consistent. You want to buy a washing machine, you go and you get your consumer reports, and you look, is this a reliable brand? Is this not a reliable brand? That's risk information too, right? I'm looking at the risk that this thing's going to break on me. If we will go out and read the Morningstar report when we pick the stocks and our mutual funds for our 401k. And if we will go out and look at consumer reports before we buy a car or we buy a washing machine, what on earth are we doing deciding life or death things in 15 minutes based upon one conversation with one doctor? Or even worse, based upon whether your coworker's mother had the same procedure. And we listen when we hear those stories. How do we get past this? Well, in the investment world, we have tools, we have research. So let me make this case, and I recognize I'm being strong here, but I think there's a reason for it. Patient decision aids are the Morningstar reports of healthcare. Patient decision aids are the Morningstar reports of healthcare. What's a patient decision aid? It can be a website, it can be a brochure, it can be a pamphlet, but it's a systematic, evidence-based presentation of the risks and benefits of multiple therapy options in a format that allows you to make that decision over time, to process that information, to think about it. You want an example? Here's an example. This is an example of some screenshots from a decision aid that my colleagues at Michigan developed for women who are considering taking medications to prevent breast cancer. Where do you start? Well, if you're going to be taking a medication to reduce your risk, you've got to start by knowing what your risk is. Here it is, in icon array format. But of course, if you've been listening to me, you know that ain't enough, right? Because you need context to put that number into meaning. So here's that number again, side by side with the average woman's risk. Now you know that at least for this woman, she's much higher than the average woman. But you still get to see that even though she's got a 10% risk of developing breast cancer in the next 5 years, she's got an 89.5% chance of not. And now you're considering taking a medication. What's going to happen when you take that medication? Well, it's going to do many things. It's going to have some other benefits, like this. It'll reduce your risk of having broken bones because it operates on the same hormones that sometimes lead to osteoporosis. So here we can see a side-by-side comparison. Turns out tamoxifen and raloxifene, about the same benefit. The risks, you get more side-by-side presentations. You can think about them. Each piece of risk gets presented systematically. And if you're sitting here going, boy, that's going to be a heck of a lot of stuff, you're right. It's a lot of stuff. So here's a summary table. Here's your options. no medication, tamoxifen, raloxifene, each of the potential risks, each of the potential benefits laid out side by side so that we can do that joint evaluation that I talked about earlier, and that information becomes valuable, and we can make a choice. Is it going to be a choice devoid of fear? Of course not. David would laugh me off the stage if I said that. But now at least we're giving you the information in a way that it might enable you to process it, to help you make sense of it. I said it before. Patient decision aids are the Morningstar reports of healthcare. And I will say that I believe they should be standard of care for health decisions that involve risk trade-offs, where the patient's values enter into the process. And if you stop and think about it, that's a lot of the medical decisions we all face, because it isn't just those cancer treatment decisions. It includes the things like, do you want to take that antidepressant, even though there is a risk that it might make things worse? Do you want to take that statin? You know how many people take statins to lower their cholesterol? You know how many of them don't know the muscle fatigue and pain that afflicts a certain percentage of them? It affects things like, do you want to have that cataract surgery that will help you to now see again, but might really prevent you from seeing at all? Those are the kinds of things. I mean, I didn't get LASIK surgery, even though I'm actually a pretty good candidate, because I know I am not willing to run the risk of losing my sight. So, strong words, huh? I'm not backing off of this statement. But you might be sitting here saying, well, what the heck does he know? You know, he's no clinician. He's never treated a patient in his life. And he's probably just made up those sort of simple patients who showed you in the slides. Well, you know what? You're right. I am not a clinician. I have never treated a patient. And I did make up the patients in the slides. Well, most of them. Because one of them is real. One of them is somebody I know very well. And that's BJ. Let me introduce you to BJ. "13 years ago, this month, May, I sat in an infusion room in Seattle, Washington, and picked up with my own bare hands 46 pills of the chemotherapy agent busulfan and swallowed them. 3 more doses followed the 3 following days. It was enough chemotherapy to kill me. I bet my life on a bone marrow transplant. The fact that I'm standing here today is only due to the fact that it worked. But if you ask me, how did I make that choice? How did I manage to come to the belief that it was the right choice to make that bet with my life? Was it easy? Hell no. Of course not. I was a graduate student in decision making. It wasn't that I didn't have the numeracy skills here, okay, guys? I knew what the numbers were. I knew what the numbers meant. That didn't mean I knew what the right choice was. But what did I do? I did some of the things that we talked about today. Right? I asked questions. What is the return on that transplant? What am I really buying for this? And is it possible that not doing it is the right choice? I got past that label of being a good candidate and put it aside and asked, okay, what is the number? What does good candidate mean? And when they said, oh, that means you've got a 70% chance of cure, I said, hey, time out. What happens with the other 30%? And in the end, I had to wrestle with the question of what did I buy from doing the transplant? And if you ask me ultimately how I came to my decision, ultimately I came to my decision by recognizing the following. Transplant was the only way that I would live long enough for my daughter Eve to know me. So I started today's talk by talking about Nick Curzon and his story of going through some of very much the same kinds of trade-offs and wrestling with the emotions and the numbers in his medical decision, and how he made sense of it by thinking about poker. And when I wanted to think about what did I want to end today's talk with, I actually gravitated back to his article, because he ended his own article with some words that I think truly, to me, capture what it means to be somebody who has to wrestle with risk statistics and make sense of them, to get from risk data to risk meaning, to risk understanding, to risk decisions. Because what he said ultimately is, what poker did for him was it helped him to come to understand risk in a way that helped him to truly understand how predictable it is to be as lucky as I am. Thank you all for your time.